Hello, thanks for dropping by to today's video where we will be discussing asthma. So we'll begin with a definition, and the definition also describes its pathophysiology. So the definition of asthma is when you have bronchial hyperresponsiveness. So it overreacts, and this leads to airway inflammation, which can be chronic over time, and this can then lead to intermittent obstruction, which would be the cause of the acute exacerbations. So bronchial hyperresponsiveness is typically there's some sort of trigger that causes the bronchial to respond or overreact to something, and then this will lead to air inflammation, which is mediated by mast cells, eosinophils, and other mediators, inflammatory mediators, and these can generally and when these become very severe, they can lead to intermittent obstruction, and this obstruction is caused either by airway edema or mucus plug. And so airway edema is created by some of those the mucus glands secreting too much fluid, and then the mucus plugs is when those plugs kind of go further down and they obstruct the bronchiole or the bronchus completely. And so what happens when you have airway edema and mucus plugs, these act together to increase the resistance, and then this decreases the expiratory flow rate. And so this is primarily an expiration type of problem, and so that's why this is considered one of the obstructive rather than restrictive diseases. So this kind of summarized very briefly the pathophysiology, enough that we need to know here. Of course, for step one, you probably need to know a little bit deeper than that, and I'll make a video about that in the future. So what are the causes of asthma? So the etiological causes, one of the causes is any type of environmental allergen. So it's almost like an allergy when they get in contact with a specific type of substance, they will hyper-response, and that will lead to asthma. Otherwise, it can also be triggered by a viral infection, more commonly by an upper respiratory tract infection. And these are done by different viruses such as the rhinovirus and even the RSV virus. And this viral infection is typically common in children, and so when you kind of think of viral infections, think of the younger age group. Next, also sinusitis, and sinusitis is interesting because 50% of people with asthma or an acute exacerbation tend to have concurrent sinusitis, so that's the kind of link there. There's a specific type called exercise-induced, and with these patients, they only get an asthma attack when they don't only get it. They whenever they do some exercise, they get an asthma attack. Now, 50% of the time, they tend to be completely silent except when they're exercising. So the only time they'll get an asthma attack is when they're exercising, and so the other 50%, they have other triggers. However, exercise is one of them as well. And generally what happens is when they exercise for 10 minutes, then they start to get symptomatic asthmatic symptoms. However, if they exercise for a shorter interval, these symptoms will occur 5 to 10 minutes after they begin resting. So that's the kind of difference there. And generally, the higher the intensity of the workout, the more severe the symptoms. So they're kind of linked in severity of symptoms and the intensity of workout. GERD is another cause, and the pathophysiology behind that is thought to be the acid in the esophagus triggers a vagal response, and so this vagal response will then generally cause constriction of the bronchus. So that's the kind of idea there. Aspirin-induced asthma, this has to do with the kind of mechanism of action of aspirin. What it does is it decreases, it inhibits the cyclooxygenase enzyme, and so that decreases prostaglandin. So then the idea is you increase the amount of leukotrienes, and leukotrienes do cause bronchial constriction. And when someone does have aspirin-induced asthma, then you want to use what's called a leukotriene receptor antagonist, and those tend to work better for these patients. Obesity is another cause. On top of that, occupational exposure. So certain occupations tend to have asthma, and these would be people who work, such as farmers and painters and even janitors. And they kind of get in contact with certain chemicals, and of course, there's probably many other occupations that people can get exposed to certain chemicals that trigger their asthma. And finally, even emotional. So certain emotions, maybe if they become suddenly emotional, that can also trigger an attack. So people need to be careful, that have that sort of symptoms. Okay, so what we'll do is, so we've finished etiology. Now let's talk about clinically what you can expect. So asthma can start at any age. However, about 75% of patients who have it tend to be diagnosed less than 7 years old. And generally with these patients, especially if they're a younger one, they tend to remit once they get into the adolescence years. And so it's not always going to be something they'll deal with their whole life. So what is the main symptom? One of the main symptoms is cough. Generally described as a non-productive cough, non-paroxysmal, and these symptoms, and actually all the symptoms tend to occur at the night or in the early morning. So that's a very, very key kind of feature there. When you hear that, you definitely want to think of asthma. The other thing is going to be chest tightness, or sometimes patients will describe it as a chest pain. So this is also something that asthma patients will tend to have. And finally, there will be a wheeze, and the wheeze initially will start off as an end expiratory wheeze. However, as the disease progresses, this can be a wheeze throughout the entire expiratory expiration. Then, as it progresses more, it's going to be on inspiration and expiration. And finally, you'll get something called a silent chest. And this means that when you listen to the chest, there is no sound. And this suggests that there is complete occlusion of the alveoli of the airway. And so obviously this is very serious. It has gotten very severe. And this is generally considered an emergency. So as soon as they get silent chest, you definitely want to treat it right away and get them at least to an ER or something. Now, when we talk about asthma, these tend to be the three primary symptoms during an exacerbation: cough, chest tightness, chest pain, and wheeze. So these are the symptoms that we are looking for. Now, as far as signs, there are some other signs that you might want to look for. One is going to be increased respiratory rate, and of course they're having difficulty breathing, so of course they're going to start breathing more. Now, as it becomes really severe, they do tend to hypoventilate. So hypoventilation occurs only when it's really severe. And this is generally due to a lack of respiratory effort. So they just end up getting tired and they can't maintain their breath, and so that's why they're hypoventilating. Also, they will get tachycardia or a high heart rate. And actually, let me just go real quick back to respiratory rate. They also tend to use their accessory muscles, such as the sternocleidomastoid. And they have something called what's called a tripod stance, where they rest their hands up against the table to kind of lift their rib cage and try to get more air. So that's called a tripod stance, and that's also considered the use of accessory muscles. Also, one of the signs is going to be pulsus paradoxus. And what pulsus paradoxus is, what happens to these patients is that on inspiration, they get a drop in blood pressure, where you'd expect an increase in blood pressure, and this blood pressure must be greater than 12 millimeters per mercury. So, sorry, the decrease in blood pressure must be greater than 12 millimeters per mercury. Other symptoms and signs that they may have is they become incredibly breathless. They're unable to speak, and when they do speak, it tends to be in phrases or words. And also they start becoming less alert, so they start becoming kind of drowsy and tired. So that's another symptom you want to look out for. Now, how do you work up these patients? Typically, it's diagnosed by either the clinical findings. So some clinicians, just based on the very typical findings and maybe even the age, they just tend to just assume it's asthma and they treat accordingly. And a lot of times the response to treatment is considered definitive. However, you could do a spirometry to confirm, and you also want to make sure you rule out other alternatives because there can be some. So one of the tests that is not really used, but you can do, is called a bronchoprovocation test. This is considered the gold standard. However, very rarely used because. Again, it's not always necessary because of the clinical findings, and also it's kind of mean, I guess you can say. So what you do is you try to test the bronchus for hypersensitivity. And one of the tests you can do is you give them either methacholine, you can give them mannitol, or if they have exercise induced, you can have them do some exercise. And so what you do is you're actually waiting for the symptoms to occur. And so methacholine is a cholinergic agonist, but a very temporary one. So if you spray this in their mouth or you give this to them, they will suddenly have a very minor type of episode. And it's the same thing with the other ones. And so if you do get this high response, that's what you're looking for. You're looking for a high response. Now, if it does become positive, that's not diagnostic actually, because you do still need to rule out other causes of a positive, and these can be COPD, rhinitis, and some of the other lung conditions that can be there. So many other that you need to rule out. So positive, you still need to do some investigation. However, if you do this and it's negative, then you can just rule out asthma. It can't be asthma anymore. So that's a kind of a nice thing about this test. But again, not really done. What actually is done and what's preferred is spirometry. And spirometry is when you look at you have the patient blow in and as hard as they can into a device which measures how much air is being taken in. And so one of the parameters that we take a look at is called the forced expiratory volume in 1 second. So this would be the amount of air that they can push out in 1 second over the total vital capacity, and this is the total ability to actually blow out air. So generally, normal individuals should be able to blow out 80% of the air in 1 second. However, people with asthma, they tend to have less than 80%. And so when you do this initially, all this tells you that this is an obstruction. Doesn't necessarily tell you it's asthma. And so the diseases of obstruction are COPD, emphysema, bronchiectasis, and asthma. So you've kind of narrowed it down to these 4. However, what do you need to do to make sure it's asthma? Well, what you can do, the interesting thing about asthma compared to the other 3 is asthma is reversible with a bronchodilator. So what you do is you give them, a bronchodilator, and you look to see, and then you do the spirometry again. And if it improves by 12% or 200 milliliters, then you've got the diagnosis of asthma. So asthma is reversible while the other 3 aren't. And the other 3 are actually slightly reversible, but asthma is more considerably reversible than the other 3. So something to keep in mind. The other one is going to be a peak expiratory flow monitor. Peak expiratory flow, so it's also written as PEF. So this image right here shows a peak expiratory flow monitor. So as you can see, it's a very cheap device. The patient blows as hard as they can here, and then they see how far it measures up there. Now, what is normal? Well, depending on your height and weight, there's a chart that you look at, and so you get the patient's height and weight, and then they give you the normal values. Generally, if the patient is between 80% to 100% of that normal value, that's pretty good. 60 to 80%, that's going to be mild, and less than 50%, well, then that's pretty serious. 50 to 80%, and if it's less than 50%, that's pretty serious, and they need to go to ER. Generally, what they use this for is for monitoring and decision making. So how do you treat the patient, what to do? And since it's very cheap and it can be used, it's fairly easy to use, patients tend to use it themselves at home to kind of monitor how they're doing. And it becomes part of what's called the asthma action plan, where depending on where they fall into, which range they fall into, you educate the patient on what to do in certain circumstances. So it's very helpful in that. And when we get to management, we'll talk about how they use that more specifically. Next that you can do is you can do blood and sputum eosinophils. So because it's kind of an allergic reaction, eosinophils do tend to be high in the blood and in the sputum. If it tends to be greater than 4%, that supports the diagnosis of asthma, but it can't rule it out because there's also other things that might do that. And if it's greater than 8%, then you do get some differentials. So I'm writing them over here. So one of them is going to be the allergic bronchopulmonary aspergillosis. Church-Strauss syndrome can also have greater than 8%, and eosinophilic pneumonia can also have that. And these blood and sputum eosinophils do help guide therapy as well, but not used as much, but they could possibly do that. And finally, you can do a chest x-ray. Now, in the asthma patient, chest x-ray is normal. So the only benefit is that it helps rule out other causes such as pneumonia and other things that might be actually causing these symptoms. So chest x-ray is there. So now that we kind of talked about the workup, the next thing you want to do is you want to try and stage the patient and see where they are at. So there's 2 main types. So there's either intermittent or you can have persistent. So the difference is in intermittent, they're actually asymptomatic between episodes or between symptoms exacerbations, whereas persistent, they always tend to have some type of deficiency. And in persistent, it's differentiated into 3 different types. It either could be mild persistent, moderate persistent, or severe persistent. And depending on certain symptomatic and assessment values, you can differentiate which group someone belongs into. So the first thing that we look at is symptomatic in the day, and that symptomatic in the day is sometimes referred to as the use of a short-acting beta agonist, or you can also be the night symptoms. So in intermittent, they'll generally have less than 2 days a week where they need to use the short-acting beta agonist, and they'll generally have less than 2 night symptoms a month, 2 days a month. In mild, however, the day symptoms are going to be 2 to 6 days per week, and persistent is going to be daily symptoms, and severe is when they have symptoms throughout the whole day. So you can see that would be pretty severe. And as far as monthly goes, so that's per week, 3 to 4 days out of the month out of night symptoms, greater than once a week in persistent, and in severe they have, again, night symptoms every night. So that's how you kind of differentiate based on how frequently they have symptoms. You also can differentiate about the activity level. So intermittent and mild, they tend to be fairly normal. Doesn't affect their activity. So mild starts having minor limitations. Persistent has some limitations, and severe, they have severe limitations. So they're not able to do many things because of their asthma. So next, what we'll do is let's talk about severe exacerbation. So severe exacerbation is defined as when an oral glucocorticoid is required. So now in intermittent, they only have 0 to 1 per year, whereas in mild and persistent, they have greater than 2 per year. So anytime you get 2 symptoms two severe exacerbations per year, you go into this category. So there is sometimes overlap. So they might have more night symptoms and less day symptoms. What you tend to do is you go with whatever's the worst. That's the category you belong in. So that's kind of how you deal with that. Now, as far as assessment values. So, of course, we can look at the FEV1, which is the amount of volume you can do in 1 second, and FEV1 over the FVC ratio. So the FEV1 is greater than 80% in intermittent and mild persistent, and it tends to drop after that. So in moderate persistent, it goes down to about 60 to 80%, and in severe, it'll be less than 60%. And with the ratio, they tend to be normal in intermittent and mild. However, in persistent moderate, it's going to be less than, it's going to decrease by 5%, and then it's going to decrease by more than 5% in severe. So as you can tell, everything will be normal as far as assessment values will be normal in intermittent and mild persistent. So it's only when you start having derangements in these values that you start becoming into moderate and severe. So that's kind of an easy way to, kind of helpful way to remember that. So now what we'll do is we'll talk about management. So now we will go ahead and move on to management. So the first step in management, and this is actually the most important, is education. And this has actually been shown to decrease mortality the most. And what you do in education is you give the patient an asthma action plan. And so in the asthma action plan, what you do is you educate the patient on what are the signs and symptoms of a severe, mild, and moderate attack, and then depending on where they fit in there, they'll know to do certain things, when to go to the ER, when to take increased doses of medication, or just it's not a big deal. So that becomes one of the most important things, and also you educate them on avoiding triggers. And so this actually means you have to identify the trigger and then avoid those triggers. So that's these are actually the most important parts of management. Otherwise, what they've designed is called a step system. And so in the step system, there's 6 steps, and depending on the symptoms, you either have them step up or step down. So generally, when you step up, you're increasing the amount of drug that you're giving or the dosages. And so you tend to step up whenever the patient has symptoms greater than 2 days a week. And these symptoms have to be severe enough to require a short-acting beta agonist. So when do you step down? You can step down when the symptoms are well controlled for about 3 months. And so why do we do this step up and step down? Well, this is because asthma tends to be a pretty dynamic disease. And so as the patient feels better, you could try to decrease the dosage or the types of number of medications. And as the symptoms get worse, you can increase the dosage or the number of medications that you're using. So this becomes very, very important. So let's go into actually what the steps are. So you have 6 steps, 1, 2, 3, 4, 5, and 6. And these are all the steps that you go through. So the first step is going to be just a short-acting beta agonist. And this is going to be generally patients who are intermittent, not persistent. And so in these patients, there's no controller that's required, and they just take the short-acting beta agonist as needed. And so if this is able to treat the patient pretty well, then there's no problem. They can continue to do that. However, if they do get more than 2 symptoms per week that require the short-acting beta agonist, so they're going to have to step up. And so in the first step up, what you do is you give them low-dose inhaled corticosteroids. So ICS stands for inhaled corticosteroids, and they take this daily. And actually, when we're talking about all the rest of the stuff, the steps, there's going to be daily medication. These are considered the actual controllers that will be required. Okay, so now one thing I want to point out is, of course, this is daily medication. However, you still want to, for quick relief, you want to still give them the short-acting beta agonists. And so whenever they have these episodes, they take these short-acting beta agonists 3 times every 20 minutes. So the short-acting beta agonists, doesn't matter what stage they're in, they'll always be, so they can be 1, 2, 3, 4, 5, or 6. They'll always use that short-acting beta agonist whenever they need any quick relief, so whenever they have an episode. In the third step, you're still using the low inhaled corticosteroids that you were using in step 2. However, you add a long-acting beta agonist. And in step 4, 5, and 6, all 3 of them, you're going to be, actually all from step 2 all the way to 6, you're using an inhaled corticosteroid. However, once you get to stage 4, instead of using a low corticosteroid, you increase the dosage and you use a medium. And you're also using a long-acting beta agonist for all 3, 4, 5, and 6. So you can see that you're pretty much using the same medication in all these 4 steps. However, what changes? Because something has to change, otherwise what's the purpose of having a step? Well, the dosage of the inhaled corticosteroid changes. So in step 4, you go to medium. In step 5, you go to high. And in step 6, you're also going to high. And why is it that inhaled corticosteroids are so popular? That's because it has been shown that inhaled corticosteroids can decrease the amount of short-acting beta agonists required. It can increase the quality of life. It can decrease the number of exacerbations that they have and decrease the loss of lung function. So because of such overwhelming evidence, you will see that, besides step 1, you will see inhaled corticosteroids in every single section. And then, of course, second would be the long-acting beta agonist. So now, if you're kind of wondering what's the difference between stage 5 and stage 6, well, in stage 6, you also add an oral glucocorticoid. So that is stage 6. Now, also in stage 5 and stage 6, they've introduced a new drug that's called omalizumab. This is an anti-IgE, and these are best for patients who have some type of allergy, especially people who have high eosinophil in the blood and our sputum. So as you can see here, this is the step. So again, inhaled corticosteroids and long-acting beta agonists are kind of found in all of them, but as you go up, the dosage of inhaled corticosteroid goes up, and once you go to stage number 6, you also add an oral glucocorticoid. So that's a good way to memorize it. But before I finish, in stage 2, 3, and 4, you can have an alternative to long-acting beta agonists, and that can either be a leukotriene receptor antagonist, and this is you'd want to use in patients when it's aspirin-induced, xylutine as well, which is the mast cell stabilizer, and then theophylline. Which not used as much because of the kind of adverse effects, but still can be, it still is mentioned. So this is how you treat, on a regular basis. However, when they have an acute exacerbation or, a very severe attack, this requires a different type of management, more emergency department and admission management. So firstly, the patient should have an asthma action plan, and in that plan, they should know how to detect when a severe exacerbation is coming. And so the way they detect it is by symptoms. So the first thing to do is symptoms. So if the patient realizes he's breathless, he's not able to speak, only in phrases and words. Also, if he starts noticing very severe cough, severe wheezing that's going through the entire expiratory or even into inspiratory, if they start using their accessory muscles or they start noticing drowsiness, these are all symptoms that should trigger them to do a peak expiratory flow. So whenever they feel these symptoms, they should do the peak expiratory flow, that small device that I showed earlier. Now, if it's 50 to 79% of their best, then what they should do is they should just take 2 to 6 puffs of these short-acting beta agonists, and they should do that 3 times every 20 minutes. And so once they've done that, they should see how they feel. So if they start to feel better, or they don't feel any better at all, they kind of want to be aware of that. And so what you want to do then is you want to do a peak expiratory flow, and so then you see what the results say. So there could be 3 possible results here. So if they're greater than 80%, which is normal, that means that they had a fairly good response. They're able to kind of go back to normal there. And so what you want to do is just have the patient continue with the short-acting beta agonist, because even though they're better, sometimes they can kind of fall back in. So you want to continue that, and you want to continue maybe every 3 to 4 hours for about 2 days, or for about 48 hours. And then after that, they do want to kind of talk to their doctor, make an appointment with their doctor, and change their medication. So that's important there. Now, if they've already done the 2 to 6 puffs, and then they take another, they check out their expiratory flow again, and it's between 50 to 79%, that's considered an incomplete response. And so in these patients, they want to go ahead and use an oral glucocorticoid, and they want to continue using the short-acting beta agonist, and again, go with the doctor and change their medications. And that's what you want to do. If it's less than 50%, that's a poor response. You definitely want the patient to take some oral glucocorticoids and a short-acting beta agonist, and then they want to immediately go to the emergency department. So so this is why the action plan is very, very important, because they can figure out, when should I go to the emergency department, when should I just up my drugs, or when should I just kind of just do what I'm doing. So very, very important that patients are aware of this. And by the way, so this is less than 50%. Even if they get on the first flow, they get less than 50%. You want to do the same management. So now what we'll do is so of course these patients are okay. They're going to go meet with their doctor, probably step up or change their medications. Now let's talk about what happens to the patients with an emergency department. So these patients, obviously what we'll do is we'll act like we are the ER docs and see what we will do. Okay, so when the patient comes to the emergency department, one of the first things you want to do is do a quick history and physical examination, because you do want to make sure that they are having an asthma attack. And so what you look for physical examination, obviously a high respiratory rate and heart rate. You're also looking for the use of accessory muscles. Also, if they're not able to talk, that's a sign that this is pretty severe, or if they have diaphoresis. The other symptom that you might want to look for is pulsus paradoxus. And so what is pulsus paradoxus? Pulsus paradoxus is, of course, we already kind of discussed, is when they inspire, the heart rate goes down more than 12 millimeters of mercury. So we kind of discussed that already. So once you've done the quick history and physical examination, you want to divide the severity into 3 groups. So it's either going to be mild to moderate, it could be severe, or they could be in respiratory arrest. So how do you decide which one it is? Again, you can do the peak expiratory flow monitoring. So if it's greater than 40%, that's mild to moderate. If it's less than 40%, that's severe. So the first thing you want to do is you want to give them oxygen until the saturation is 90%. And that doesn't matter which group they're in, whether they're moderate or severe. The first step in management is oxygen. Now, say you give them oxygen, so they have less than 40%, you give them oxygen, and you can't get to 90%. Well, then that is, you can't do it, so then you're going into respiratory arrest. Immediately you want to intubate the patient and begin mechanical ventilation, and the mechanical ventilation needs to be at 100%, and then admit them to ICU. So that is very, very serious, and they need to, it's life-threatening, so you need to get them that right away. And again, those are with patients, when you give them the oxygen, they can't even get to 90%. Okay. Otherwise, in mild to moderate, you can just give them oxygen, then go ahead and start a short-acting beta agonist, either by nebulizer or with the inhaler. And in severe, you want to do the short-acting beta agonist with ipratropium and an oral glucocorticoid. If it's mild to moderate, oral glucocorticoid, that's a maybe, depending on maybe the symptoms. If the symptoms are a little bit more severe, you might want to go ahead and add that as well. But it's depending on the clinical assessment. So once you've done that, for about an hour, you want to go ahead and you want to reassess the patient, see how he's doing. And again, reassessment is done again with the pulmonary, the peak expiratory flow monitor. And so we divide them again, depending on the next flow, we divide them into 3 groups. So if they begin to react greater than 70%, you consider that as improving. So you go ahead and you continue doing short-acting beta agonists every hour. You give them oral glucocorticoids, and you observe them for about 4 hours. So after you observe them for about 4 hours and they seem to be improving, you can go ahead and discharge them. And when you discharge them, tell them to continue the short-acting beta agonists, continue doing the oral glucocorticoids, and even maybe the inhaled glucocorticoids. So again, even though they might have gotten better, you still want to try and prevent any type of re-stimulation. So that's improving, which is around 70%. If they're about 40 to 69%, that's considered not improving. And so in these patients, since they're not improving, you want to just go ahead and admit them to the wards. And in the ward, you want to go and continue the oxygen, continue the short-acting beta agonists, oral glucocorticoids, and you want to just monitor them, check their vitals every once in a while, and then their forced expiratory flow and velocity in 1 second. You want to continue to monitor them. And then, so continue to give them that until they get over the episode, and then you can go ahead and discharge them. Now, if it continues to be less than 40%, that means they're worsening. Oftentimes these patients tend to have a PCO2 of greater than 42, and so what that means is, because generally patients tend to have low CO2 because they have hyperventilation. So as soon as they start accumulating CO2, then that means they've lost respiratory drive and they're in a very serious state. And these patients also have very severe symptoms. In this case, you want to admit these patients to ICU. And in ICU, of course, you're going to give the oxygen and the short-acting beta agonists. Those are kind of hallmarks of treatment. But on top of that, you'll give IV glucocorticoids. You'll be intubating the patient, and you'll be giving mechanical ventilation so that obviously they can try to get over this episode. And once you've done that and they kind of stabilize, then you can admit them to the wards and continue monitoring and vitals. And then once they get better, you can go ahead and discharge. So this is just a overview of the asthma. So hope you guys found that beneficial. See you guys in a future video. Bye.
This is the appearance portal, going where no one has gone before. Welcome to the program tonight. I am Augusto Perez, and tonight we have a treat for you. My guest tonight is Gil Brazzard, amateur astronomer and researcher. And we will be talking about a topic that a lot of people don't know much about and really are totally in the dark about, but very, very real, very interesting. Not many people talk about it, and that is Planet X, also known as Nibiru, Destroyer, Wormwood, and many other names. So tonight I want to welcome to the show Gil Brazzard. Welcome.
Okay. Thank you. Thank you, Augusto. And
well, if you could just share a bit with our listeners tonight, Brother Gil, what about your background, what brought you into this interest in this topic, and and some of these things to bring you where you are today.
Okay. Well, it started with a phone call. A friend of mine called me, and he asked me if Planet X was real and if it was biblical. And at the time, I told him that Planet X was not real, and that I'm pretty sure there wasn't any astronomical evidence for such a planet. And so after the conversation, I said, if I'm ever asked that again, I need to get the actual data together to better answer that properly. So I started to do a search, and And I came across my own data in the Chinese records, and that kind of really started it all off. Yeah. And actually found a white paper, a scientific white paper report called the Reevaluation of the Eastern and Western Records of the Supernova of 1054. And what that did was it proved that our assumptions that it was the supernova, that it ended up proving it wrong, that this object was actually moving through the night skies, as documented by the Chinese and the Korean and the Japanese astronomers. And so when I read the article, I decided to attempt to plot its orbit, because the data was so, they had done such a good job in stating where the object was, the brightness, the time, the year, the day, all of the criteria that we need to try to have a plot of this orbit. And they had multiple sightings of it within a 26-month period. And so out of that, what astounded me was that the plot of its orbit ended up matching the biblical parameters, where, like in Noah's flood, it says it's 150 days between the time that it started raining to the time the flood started to recede. Mm-hmm. And that's equal to the same time frame as in Revelation, where it says from CO6 to CO7 that they wish death for 5 months, but death will not come. Well, 5 months is equivalent to 150 days.
Wow.
And this object is plotted coming into the month of Passover and exiting, well, it comes in the end of August. It goes around the sun, and then it exits during the month of Passover. And that was quite astounding and shocking whenever you find actual white paper reports that match or mirrors a biblical event or an object that's occurring in the same way as the biblical accounts are. And so
yeah, that is very interesting. And I had read that several times, and I had never connected the dots between the event in Noah's days and the event in Revelation. That is the same amount of time, 5 months. And when you begin to connect these dots, it makes a whole world of sense. And it is fascinating in the sense that the Almighty uses these celestial events to bring about cataclysms on the earth, or maybe they come and the Lord uses them to bring about whatever ends He needs to bring about. And there is a misconception out there in the world, that God doesn't need Planet X, He doesn't need this, He doesn't need that, and that is true. He doesn't need, but He uses many times these celestial objects, and the Bible talks about how the Lord has given the celestial objects and the constellations as a sign for mankind here on planet Earth.
Well, you can take the story of Jonah. Mm-hmm. Whenever they asked Yeshua, when is this to be taking place, he said, the only sign that you will have would be the sign of Jonah. And there's only 2 pages to the story of Jonah. One was the 3 days in a whale, which Yeshua also used that one pertaining to how long will he be in the grave? 3 days and 3 nights, as in Jonah. But for his return, he says the only sign for a wicked nation will be the sign of Jonah. And when you read the second half, most people don't get the emphasis. It's more on what's not being said. Jonah convinced an entire town and its king to repent, but he didn't perform not a single miracle. How is that possible? Because the models show us that in 40 days, he said, your doom will come. The model shows us within 40 days, this planet is clearly in the view of Earth and is gaining in size as it's approaching Earth. That's what was, because they already, the people of Nineveh recognized the signs of the earthquakes, the birds dying, the fish dying, the same things that we're seeing today. They knew something was wrong. And when Jonah pointed to the sky and told them that this is your doom, that's why they believed it. And for Jonah to know that, well, God gave him the information as far as the timing and when to do this. You can see the fingerprint of God throughout this on the timing. You know.
Mm-hmm. Yeah, that is true.
So,
that is true, because he comes out of nowhere and starts telling them that Nineveh will be destroyed in 40 days. And
sure.
immediately they go into sackcloth and ashes mode and begin to repent. And so, yeah, absolutely.
And then he spared them. You know, he spared them.
Mm-hmm.
You know? But I don't think this nation is willing to do that at the moment. So
yeah, not at the moment.
Tough times coming.
Now, why do you call this planet 7X? I've seen that, and
sure.
Would you explain that to our audience tonight?
Yes, there is two main reasons. One is to separate the data on what's being said, like the 3,600-year orbit and many other false impressions on pertaining to this planet. And I can prove this out later in our conversation. The second one is we happen to know approximately the size now. There's three ways of calculating the size according to the data that's given in the biblical accounts, as well as, you know, some of the Chinese accounts. And it roughly calculates between about 6.5 to 7.5 diameters of Earth. So I kind of took the average and I said 7. So I called it Planet 7X. At the same time, it helps to separate the data. When someone says something, you know where they're getting the information from, whether if it's the Samaritan text, Stitchin's work, or if it's someplace else on Earth, or if it's from the Chinese and the data that I've accumulated from the Bible. So that makes the distinction in the conversation as far as where the data is coming from.
Now, there is a very, very interesting comment that you brought up, and we talked about this when we had an opportunity to chat on the phone for a while. And this is something that kind of separates you from some of the other Planet X researchers, and that is in the orbital time
right.
that it takes for this object to come by this area. You know, it goes around the sun, it passes near planet Earth in our solar system, and then it goes back out into space. Now, I had always heard, and this comes from the Sitchin theory, 3,600 year plus or minus, and there are others that say maybe 2,000 years, 1,000 years, but according to what you have researched in the Scripture and through other means that you have researched, other data, it's approximately 319 to 324 years that it takes for this orbit to be completed. Could you talk a bit about that?
Sure. For once, another point is that I'm the first one to get actual scientific data from the Chinese or anywhere that's actually verifiable in a model. Okay? This is not hearsay. This is from a scientific report that's been through the peer review. And they list it as a NEO, a near-Earth object. But when I plotted it, I found out that it was the biblical model, and this is going to be our planet X. Now, if you go with 3,600-year orbit, and people say this was Noah's flood, well, you missed Noah's flood by over 700 years. So what event could have done if it's not Noah's flood? Two, the Chinese saw this in 1054. That's less than 1,000 years ago. So how can it be 3,600 years?
Yeah, that always presented a problem to me.
Exactly. Once you start ironing out the problems, it narrows down the data to a reality. And what does it match in the real world instead of the make-believe? Now, you see, but what's common in reading ancient languages, anything over 1,000 years ago, zero did not exist. Zeros are implied in the text. That's left up to the interpreter to put as many zeros as he wish within reason on trying to estimate what they're trying to say. So Titchen, when he read the clay tablets, what he literally read in the clay tablets was 6 times 6. Now, because of other data, they could tell the ancient Samaritans had a 60 unit of measure, 60. So he put the first number at 6 being 60. Then the next one, he said, well, on his memory alone, he's saying, well, it hasn't come through here before. So he dropped the number in there that it must be 60 times 60. Well, that gives you the 3,600-year orbit. But if you were left it at 60 times 6, he'd got 360-year orbit. It's through an assumption